peritoneal dialysis is what?
Peritoneal space.
Okay. Biggest complication
Infection.
related to typically, related to
At the opening.
doing it at home, contaminated tubing site, because they hook it up to your catheter. And typically it's in the home environment, that'd be great, might be a healthcare provider doing it, all those other things that, your patient's caregiver calls, says, I got the dialysis fluid into mom's belly, it dwelled, now I can't get drained, you're gonna tell her to do what?
Turn to the side. Turn to the side.
Bring the head of the bed up.
Reposition mom, but don't mess with that catheter, because the surface was placed there. Any questions about assessing a dialysis, device? You're the nurse, I have one in my arm, do you know how to assess it, and what's normal and what's not normal, all that good stuff. Patient education, that's pretty straightforward, take good care of that arm. Don't be carrying heavy purses, bags, blood pressure, vein punctures, all that kind of
Patient's lifeline.
stuff. Pardon me?
Patient's lifeline.
Yes, it is, so don't mess it up. Kidney transplant surgery, what are your two criteria that's gonna warrant you calling that surgeon about?
Hypotension and excessive diuresis.
But don't you want diuresis?
Not dehydrated in the kidney.
Okay, so what is the milliliter difference that you're gonna be? Do you care about 100 milliliters difference, or what's
Like
sort of,
2,000 or something like that.
something like that? Typically, we say anything more than 500 difference. So if we give you an intake, following you're taking care of your patient post kidney transplant surgery, we give you an intake and we give you an output, do you recognize that the output's way more than the intake, and that's, you're worried about getting that kidney dehydrated?
So then, never mind.
Call the surgeon. So given this patient's information, you're gonna call the surgeon about what findings. And we'll give you an intake of 1,000 and an output of 1,200. I'm not worried about that one. But you gave me a blood pressure of 92/60. I am worried about that one. Or I'm worried about both of them. That tells me that you understand those two aspects. That new kidney has to get blood, the new kidney has to get fluid. Questions about that? Urinary diversion devices, yes, there'll be questions about those. Which ones have a stoma, which ones need to get catheterized, which ones need to have a bag on the outside, which ones have a pouch on the inside. Tell me the teaching goes with neobladder, all of those things. Anybody have questions about those? I'm not gonna ask you incontinence questions. Yes, I'll ask you kidney stone questions. So for the sake of time, just look those over. There's lots of treatment options. I can do an IV fluid. I definitely need to give you pain medication. I can do an IV fluid to get those things moving through. I can give you a medical expulsion therapy, which means I give you something to relax your urinary muscles in the hopes that they relax and get your stone and cruise on through there. I can put in a stent, which means I open up your vessel to get your kidney stone to move on through. I can do an otomy, right? Make an incision right into where it's stuck. And I can put a little device in there and pull your stone out if I have to. I can put worse things worse. I can put a catheter right into your kidney itself, nephrostomy, and let that drain. I could do shock therapy, which is called lithotripsy, jackhammer on the outside, and hopefully you can void it out on your own. If I can, I might send you home with a strainer. You can catch the stone yourself. If you do, I might be able to analyze it and decide if it goes with some kind of dietary thing that you're doing. You've had 3 kidney stones last year, all of them have been calcium formed, so we probably need to talk about you restricting your calcium intake. So yes, there is a correlation sometimes. Hydronephrosis is what? Urine that's stuck in there that can't get released. So that could be the case with this. It could be, that's what you actually call urinary retention. That word means that you've got, so your patient that presents with a kidney stone is having probably severe renal colic pain because they got urine built up that they can't outflow, and they could have, of course, hydronephrosis, which means they've got urine in there that can't come out. Severe pain, vomiting, nausea, blood pressure is low. A lot of times the nausea and vomiting is from directly to their high pain levels. So yes, you'll have management of that as that occurs. fairly frequent basis with a lot of different kind of patients. Bladder cancer, biggest risk factor. Yeah, exposure to chemicals, and we were talking about diuretics. That's that. Pause and process the question. Think about your notes. Your patient comes in with PKD. What do I know about that? Let me think about that. So that's the best way to tackle the test questions. Pause and process, see your notes for a little bit. Let me just think through this. Or spit stuff out before you get your brain full. Write it out on here, draw it out on here if you need to, or whatever it might be. Same thing for these, don't get overwhelmed. If it's an anemia, what's going on? If it's a leukemia, what's going on? If it's a lymphoma, what's going on with my lab values and which one's out of whack? And that's the easiest way to kind of keep those all stored through in your head. Or write out normal hemoglobins, normal red counts, normal white counts if you have to. Because you know when you get to those questions, then you're not gonna be stuck. You're like, okay, I'm just gonna look at my notes, and here it is, that number's too low, that number's too high, or whatever it is. You'll do fine, people do fine on it. You're coming to the end, you're knowing how to process those questions. If you have questions between